All right, well, good morning. I think I know everybody, but on the slight chance that you don't, my name is Linda Schoene, and I am happy to be here to talk about this little gem of a book called Pluck, Lessons We Learned for Improving Healthcare and the World by Dr. Alfred Sadler and Blair Sadler. It was Peggy Johnson that turned me onto this book. She gave me just enough of a little snippet that I was intrigued. And then, of course, because it's about healthcare, that's my wheelhouse. So I was further intrigued. And the really special thing is the authors are her cousins, and they are here with us, Dr. Alfred Sadler and Dr. Blair Sadler. They both live in California. And so they got up early to be here with us this morning. So I will run through my thoughts on the book and then turn it over to them to comment on my comments. And
your book in front of me.
Yeah. So we'll see how this goes. But as I read this book, I discovered that it was really the story of all the healthcare changes and advances that had occurred since I graduated from high school. So I thought, well, this is a nice little timeline and a review. And of course, like most people, I knew these things, but had really forgotten about them and hadn't really translated them into the context of life today. So the three areas that are presented are organ transplantation, and along with that, bioethics, emergency response, and healthcare workforce crisis that have started in the 1960s. These two gentlemen were in the forefront of it all, and they worked toward improving healthcare as a team. Fred is a physician, Blair is a lawyer, and they came up with the idea, what if we sold ourselves as a team, as a package? And so their association of twins is interesting analysis as well. And they brought unique opportunity. They were given unique opportunities, as well as they made unique opportunities work for them in the area of healthcare. So they started down the road of discovery and service. And I think Pluck is a good title for the book, because they indeed had resolve, audacity, courage, with perhaps a little bit of luck. They might say that part of their success was being in the right place at the right time, which might be true, but I think perhaps it was more asking the right questions at the right time, paying attention to the answers, and saying yes to unexpected opportunities, and then relentlessly pursuing the information received as it went step by step by step toward the goal. And an example of how they finessed their pluck into an opportunity involves the game of squash and Chief Justice Earl Warren. Blair saw Chief Justice Earl Warren at the squash court while he was waiting for Fred to finish playing. And what started as a simple question to the Chief Justice about whether or not he played squash eventually led to an invitation for them to join the Chief Justice in his chambers to discuss the Uniform Anatomical Gift Act, which turned out to be a critical piece of successful transplantation processes. The transplant process in the late 60s, the laws and the guidelines were a little haphazard. They weren't coordinated, and it was difficult for transplantation at that time. The things they were transplanting, they weren't doing major organs at that time, but it was a difficult process and brought up also questions of ethics, of who can consent, those kinds of things. But Christian Barnard in South Africa changed all of that in 1967 with the first heart transplant. And of course, living here in Houston, we know all about the work of Michael DeBakey and Denton Cooley and all that they contributed to that work. I had just started nursing school when the news of this transplant came off, and it's like, wow, this is interesting. And of course, working with the heart, that really brought this whole subject to greater scrutiny and brought it to light. Because up until then, working on the heart was something you did not do. You don't go there. The heart is God's organ. You don't mess with it. And there's a very good movie out there called Something the Lord Made. It features, I think it's Alan Rickman and Mos Def. And it tells the story of Dr. Alfred Blaylock, another name that we see here in Houston. He began his work at Vanderbilt, and he focused a lot on the treatment of shock, which was really helpful during the years of World War II. He then moved on to Johns Hopkins, and that's when he became intrigued with a condition called tetralogy of Fallot, which is a birth defect involving 4 mishaps of the structure of the heart. And these children were referred to as blue babies because the way their heart was structured, they were unable to really get oxygenated blood throughout the body. And this intrigued Dr. Blaylock. So he was the first to really focus in on what can we do to fix these hearts. He took a lot of pushback from Johns Hopkins, of all places, but he pursued it. Dr. Denton Cooley, interestingly enough, was one of the group while he was there that actually was willing to engage in the process. He found a successful fix and did many surgeries, though unfortunately, as you know, like the transplant process, many early fixes were not long-term, but he certainly made advances. And people came around after his success to say, oh, maybe working on the heart is okay. So this just opened the door for lots of things. And with the advancements, it became a ton of questions, like how would organs be harvested, transported, all of that. When would they be harvested became a huge question because, as you know, organs need to be perfused with blood and oxygen if they are going to be suitable. So when do we take them? Of course, that went down the road of bioethics and also to the eventual definition of brain dead. So in other words, the brain is no longer functioning. Yes, the heart is still pumping and perfusing, but essentially the patient has died. So that made a big difference, but that was a big discussion, as was the consent process. And along with that, okay, how do you coordinate from state to state? How do you get organs across state lines when every state has their own little set of guidelines and protocols? And thanks to the efforts of these gentlemen and other people who worked not only on the transplant process, but the aftercare development of drugs to suppress the immune system and lower the rejection rate, all of that. And all of that came to impact me fairly personally with my stepmother. Before she married my father, so that would have been like 1965, she was shot in the abdomen while she was hanging up laundry. That's a whole other story. But she received a couple of units of blood, which we think is where she got hepatitis C. Though it took 30 years for it to really rear its ugly head. But when it did, it took a toll on her liver. And I went up one weekend to care for her and give my brothers a little bit of a respite, and ended up taking her to the doctor's office. And I knew that my next visit, she was going to be on hospice care. Well, we're sitting in the doctor's office in Rochester, New York, and he reaches over and pats her on the knee says, we're going to get you transplanted. At that time, I think she was 77, maybe. Well, that was a Friday. The following Tuesday, I get a call from my brother. They have a liver hormone. So thanks to a wonderful unknown gentleman and his family in the state of Pennsylvania, he'd had a massive stroke and he donated his liver. The transplant went well, the aftercare went great. And because of all of that, she had another decade of quality life. So the second area, emergency medical services. They really, in the 60s, offered you a ride, you know? It was like calling Uber, you know? So there was minimal ambulances, they weren't trained, there was no equipment on board, all of that. And can you recall life before 911? What was it like before we had 911? Well, I had to dig a little deeper into my memory bank. But when there was no 911, in my experience, I called my grandfather. We called him Bumpa. So as you call Bumpa if there's a problem, because he was the chief of the volunteer fire department. So we could always reach him. He was always at the fire department because there were no cell phones or anything. And these instances I'm describing, I have no idea where the parents were in all of this, but you know, they didn't leave us, you know, completely unattended, but no way to get a hold of them. So you call Bumpa. When my brother, one of the first times I babysat him, he had a little toy plastic razor. You see, they pretend to shave. And then one night he decided to use my father's real razor. So I go to check on him, blood all over the safe. I follow the trail to his bedroom, and he's got the scar he wears today, right here. So what do? You call Bumpa. And so Bumpa puts him on the kitchen table, applies pressure, applied a Band-Aid. He probably should have had stitches, but he didn't. We stopped the bleeding. Bumpa put a Band-Aid on it. It was fine. Then there was the time that my sister hit him in the head with a golf ball, totally by accident, but full swing. I heard it crack, and I was in the kitchen. And now I don't remember him being totally out, but again, we call Bumpa. Bumpa puts him on the kitchen table, checks him out, and he's fine. Never had any follow-up, just the care of Bumpa. My brother has lots of memories of lying on the kitchen table and opening his eyes and seeing, oh, hi, Bumpa. The other issue, not only no 911, but no ambulances. If you needed an ambulance, some towns, the coroner had an ambulance that could transport people. Funeral directors, usually for obvious reasons, had at least not an ambulance, but a vehicle that you could actually put someone in. In my little town, the ambulance actually came under the fire department, the volunteer fire department, and Wally was the driver. So you could call the fire department and Wally would come. So neighbor across the street called me, and their housekeeper had fallen down the stairs. And she had called the fire department, so Wally was coming. So I went over, and there's Wally's ambulance, and Wally's helping her. And you could hear his radio is going crazy. You know, Wally, what are you doing? Where are you? You know? So he told me how to use the radio. So I go out to the radio, get on the radio, say, Wally's doing such and such, and you know, he'll get back to you when he can. Oh, okay. And so Wally and Ingrid, my friend, got Star. Yeah, they somehow got her into the ambulance, got her the care she needed, and she recovered. She was fine. Wally, I think, actually had oxygen too. Was when my grandfather and my grandmother celebrated their 65th wedding anniversary. He had just gotten out of the hospital. He'd gone from ICU to home with 9 new meds, but it was his party and he was going. And so we called Wally, and Wally came to the party, parked the ambulance outside with the oxygen, just in case. So that was the state of emergency medical services at that point in time. And since then, of course, a lot, yes.
There were emergency rooms though in hospitals, right?
I bet you the authors can answer that question. I think they were minimal. Emergency medicine wasn't even taught in med school. That had to happen. And then services needed to expand. And that took a lot of doing. And then who are you going to train? One group of individuals, which we'll get to when we talk about physicians' assistants, was they could tap into the military who had experience. But the whole development of the concept of emergency medicine was quite an undertaking. And as I think back, what would we do without 911 now? The last issue that is discussed is the healthcare crisis. In the mid-1960s, when Medicare and Medicaid became realities, of course, that opened up healthcare for a lot of individuals. And there weren't enough doctors and nurses to really care for these individuals. So what to do about that? Where can we get more trained individuals? One of the places they tapped into was medics from the Army, because they had at least some basic training. But then where do you go from there? What will the training look like? How long will it take? Where are we going to train these folks? And then once we train them, how do we protect the public? How do we certify? What does that certification look like? And again, like with all the other health issues, how are we going to make this translate from state to state when each state has its own idea of how things should work? So now, today, many of us have received care from a physician assistant or a nurse practitioner because we couldn't get in to see the doctor. And I had that experience and been fairly happy. And it's a wonderful career for a lot of individuals who don't necessarily want to go to medical school, but that they want to be involved in caring for individuals. My daughter-in-law is a certified nurse anesthetist and just loves her career.
Knocking people out.
Yeah, I tell you, she can put you to sleep perfectly and you will wake up feeling good. That she does a good job. So again, thanks to all the changes that have occurred, those opportunities are now available. And then finally, there are 15 lessons that they learned. And I wanted to share just a couple. One is called Lead from Any Chair. A person does not need to oversee an organization, initiative, or team to have a meaningful impact. When people bring their skills, talents, and perspective to the table, they can lead from any chair. This does not mean take over the meeting, prove your worth. To us, leading from any chair means sharing what you see, offering what you have, and having the courage to step forward, all in the interest of helping your group or organization move closer to its shared goals. And then number 7 is sometimes persistence is the only option. Shirley Chisholm, the first African-American U.S. Congresswoman, said, if they don't give you a seat at the table, bring a folding chair. Progress requires persistence, knocking on doors, finding allies, asking favors, taking risks, pushing past internal and external barriers, and breaking down seemingly impossible challenges into manageable steps, then walking boldly forward, flanked by your partners. And I found this book to be very written very concisely, with a very factual format. It is well referenced if you want to dig deeper. Several pages of references. There's also a wonderful index, which I used. I said, oh, I know we talked about this. Where was it? So I was able to find it. So that was wonderful. And the other beauty I'll show you one example. It's just one page, but there are 3 of these, one for each of the areas. There's a timeline that describes the progress. And that really impressed me because I'm reading all of this and I'm thinking, wow. Then I looked at the timeline. And for example, the one on transplantation, their work began in 1967. And by 1970, a uniform organ donor card is adopted for use by all organ donor groups. So a lot of progress in what I see, not to diminish all of your work, sirs, but what appeared like a relatively short period of time.
The end is 1970.
Yeah.
When did that start, the effort start?
67, their work.
So in three years.
And that's just one component, of course, of the whole process. But to be able to collaborate, I think is amazing.
When was the book published?
Just in, well, 22, I
Okay,
think.
that's up to date.
Yeah, it's on, yeah, 22. Yeah, so it's hot off the press. And as they reflected back on their work about the time this book came out, The Tipping Point by Malcolm Gladwell, they could see how they actually followed a lot of the principles and ideas that are in this book. So this would make it, if you haven't read it, might be an interesting companion read for this book. Because The Tipping Point is all about how to share ideas and get them to catch fire and make progress. Personally, I think this book would make a great graduation gift. In fact, I've already thought of one person I want to send it to. And also for yourselves or anybody you know that's maybe starting a new position, wants to make a difference. It's a good read in the sense that it flows very easily. It's a short book, but packed with lots of good information. So what I would like to do now is turn the microphone over to Fred and Blair to offer their comments, and then we'll definitely have some time for questions.
Well, thank you, Linda. So this is Fred. I'm Alfred, go by Fred, and I'm thrilled to start out. Thank you for that very nice review of the book. So to make it clear, that we were talking about the period that we worked together, it was 1967 to 1976, a 9-year period, 3 years at the National Institutes of Health as part of the Public Health Service. While the Vietnam War was raging, we were fortunate to be able to get positions as a medical legal team in the director's office of the NIH. And that's where we did our work on transplantation and then later on the workforce issues that Linda mentioned. And then we moved on to Yale and started one of the first physician assistant programs in 1970, and then got very involved in emergency medicine because the head of surgery had asked us to run something called the Yale Trauma Program, which was to look at the care of individuals outside the hospital, which was in very basic form, just sort of catch and haul. And as was mentioned by Linda, we didn't have sophisticated ambulances then. There were emergency rooms, and we used the state of Connecticut as our social laboratory to study the state of EMS in, or the lack thereof, in the state of Connecticut. And there were studies going on elsewhere in Illinois. But it's interesting that the federal government, when they were funding ambulances, that was under the Department of Transportation in the late 60s. It wasn't even under healthcare. And so 35 hospitals in Connecticut, 179 ambulance companies, all different. The level of training was mixed. We were fortunate and this is where the luck comes in. And I think Linda defined why we came up with the title Pluck. We were looking for something catchy, and this editor came up with it for us. Pluck meaning courage, chutzpah, gumption. So if you have an idea to do something, you need to take some action. Well, the last 4 letters in Pluck, of course, are luck. So it's amazing how lucky we were after we took action in these various areas to have an opportunity to work with other leading people. And then the final 3 years we worked together was at the Robert Wood Johnson Foundation, which had just been launched on the national scene in Princeton, New Jersey, as the largest foundation in health. And they were very interested in improving healthcare for this country, not international work, but locally. And so they got involved in workforce issues and in emergency medicine in a big way. So that's the background of where we worked and how we got started. But we were rookies. We started at age 26, and I was just finishing up my internship at the University of Pennsylvania Hospital, and Blair was a clerk for a judge in Philadelphia. And we'd given some talks together on the Good Samaritan issue and how medicine looked at stopping at the scene of an accident differently from how the law might look at it. And that had been well received. So we had the idea that maybe we could do something together as a medical legal team. Ran this by our professors in medical school and law school, and they said, go for it. And then we're fortunate enough to have the former Surgeon General, Dr. Luther Terry, who wrote in 1964, "Smoking is hazardous to your health." You may remember that when he took on the tobacco industry. He had moved to the University of Pennsylvania to be vice president for health affairs after he stepped down. And we called his office, had written a 10-page manuscript on issues of where medicine and law overlapped, some of the things that we just talked about, but also the use of human beings in research, the definition of death, those sorts of issues. And he apparently was fascinated about it. So when I called his office at the University of Pennsylvania, he was glad to meet with us. He thought it was a great idea for a doctor and a lawyer to work together. He said, we've never had a lawyer in the public health service before, but it would be terrific. And call these people and tell them Luther Terry called. So he gave us the phone numbers and the names of Bill Stewart, the next Surgeon General, Jim Shannon, the director of NIH, and we made calls, went to Bethesda, Maryland, and because the NIH is part of the public health service, as is the CDC, as is the Indian Health Service. So if you are lucky enough to be able to get into the public health service in one of these areas, then you can do that instead of working in the other areas of the military where you might get shot at. And certainly there was a doctor draft then, there was a universal draft back then, as you probably lived through, a lot of you. So we were fortunate to not have to be dodging bullets in Vietnam. So I think I'll stop with that and turn it over to Blair, and he can pick up, and then we can go back and forth. But well, maybe I'll just say one other thing, just very quickly on the transplantation. We were talking about luck. So we're there, and the first issue they wanted us to look at was the use of human tissues in medical research. It was actually around pituitary glands. They had a whole study on hypopituitary dwarfs and dwarfism and that condition. And the only way you could get these children to grow past 4.5 feet tall would be to give them injection of human growth hormone. This was 20 years before it was synthesizable, which it is since the 80s. And so it's that problem of getting it from cadavers has gone away. So they were collecting 72,000 pituitary glands a year. And when you figure we're doing 40,000 transplants a year, you see what a mammoth program it was. They got into trouble in a couple of coroner's offices where the aide was taking the pituitary gland without consent, and it had nothing to do with the cause of death, which is why the person that had died was in the coroner's office in the first place, or the medical examiner's office, to determine the cause of death, whether it was a violent death or infectious disease. So we were asked to look into the laws, and that's when we went to school at the Georgetown Law Library and learned all about the different state laws. As Linda said, they were different. There were 4 different laws relating to autopsies, to transplantation, to donation, to the coroner. And then we discovered this marvelous group of lawyers that most people don't know about, called the Commissioners on Uniform State Laws, that was founded in 1892 because a very bright lawyer had figured that, the the Constitution says that this is an area of state law, but wouldn't, whatever the issue was, in this case, it was transplantation, benefit by having all the state laws be the same? How do you make that happen? Well, let's form a group. So they'd been working for 70 years at that point and had a whole number of model laws that they would work on for 3 years or so and meet annually and discuss. And they already had a committee under a marvelous former professor and dean at the University of Michigan Law School named Blythe Stason, who was working on a model law already. He heard about our work, we heard about their work, we ended up working together and becoming his chief consultants. The model law came out in 1968, and it was passed in every state by 1971 and the District of Columbia. And so we got to testify and write and talk, and then there were international meetings that we were invited to, and talking about luck, the fact that Christian Bernard, as Linda said, came along 5 months after we were at NIH and did the first heart transplant. So this little niche area of pituitary glands and dwarfism became a widespread national issue that was of interest to everybody. How's that heart patient doing down in South Africa? Front page news every day. And then Denton Cooley and Michael DeBakey and other great surgeons, Alfred Blaylock at Hopkins, as she mentioned. So that was the exciting part. We were rookies in all these areas that we got started in, but it was very exciting to be part of on the ground floor of getting a model law and then seeing it get adopted. It's based on consent. So it gives us the right to donate, to take effect after death. And then it also, if we have not made a decision, it gives the next of kin the authority in a specified order of priority, starting with the surviving spouse, the authority to donate. So that's all laid out. And then it talks about other details about the recipient organization and their rules and laws. And then, of course, that was 1971. And since then, there's been all these great advances in the use of cyclosporin in 1984, and then other drugs that prevent the rejection of organs. But there's still the issue of coordination and all of that, which is a whole nother detailed topic. So Blair, I'll turn it over to you.
Thank you, Linda. First of all, Linda is so good. I think we should just, I'm 4 minutes younger than Fred, which means I got 4 minutes less sleep. So I think I'm going to go back to bed and just say, Linda, why don't you take it from here? No, not really. Linda, as a great summary, I'd like to sort of shift the conversation from healthcare to any issue, and from yesterday to today, because I think what is in many ways, and Linda referred to, the most important chapter of the book is chapter 10, and these 15 lessons for catalyzing change. She mentioned a couple of them, and these are things that anyone in this room, as you read it, might say, oh, that's a good reminder. I can lead from any chair. I don't have to be the head of something or the director of something. I don't have to have a title. I can volunteer. I can mentor. I can write. Some of our others are find and develop your voice. Find and develop your voice. So if there's something you care about and you want to share your interest with someone else, how would you do that? How's your speaking skills? How's your writing skills? Where would you go? Going from rookies to expert is been, Linda's talked about, but we all feel like rookies when we start out, right? But it's never too late to get involved. And that's one of the big lessons. In many ways, it's the core mindset of the book, which is dwell on possibilities, having a possibilities mindset. suppose what could I do in Houston or wherever I am that could help climate change? And is there anything I could do to deal with the intense heat and wildfires we're experiencing, or support people at my local hospital? Or some of the stories in chapter 10 that we talk about. Candy Leitner may be a name familiar to you. Candy Leitner was driving her 13-year-old daughter, Carrie, to an event after school. They were hit by a drunk driver, and her daughter was killed. Candy Leitner took that terrible moment of grief and transformed it into saying, I'm going to do something about this. She created an organization called Mothers Against Drunk Driving, MAD. I'm sure you've all heard of it. And it's now 40 years old. But where did she get the courage and the pluck to say, I'm going to do something about that? And so she was a rookie when she started. And is this an issue of changing state laws or federal laws or driver requirements on alcohol levels? Maybe it's a lot of different things, right? And just like we were diving into some things brand new about, well, what are the laws relating to organ donation? She must have done the same thing. Another example we talk about is Helen Haskell. And her son died at Johns Hopkins through some system errors in care when he was 14. And she created a national organization to mobilize parents to become more involved in their care and to be advocates for improving care in hospitals, and created a whole national movement. Gary Cohen, who's a good personal friend of mine who lives in Boston, was a travel writer in India in his late 20s. He's now in his late 60s. And the Union Carbide explosion occurred. It's like the Chernobyl, right? Only it was 20 years before. And millions of people were killed due to the recklessness of the company in terms of dealing with risk. And he said, I don't know anything about climate change, but I'm going to get involved with that. And he came back to the United States, and we talk about taking the road less traveled as one of our lessons, taking the road less traveled. And he said, I don't know anything about climate change, but we got to be able to do better. And it turned out that hospitals, which I spent a lot of time in a children's hospital here in San Diego for 26 years, weren't really aware of their carbon footprint. How much unnecessary use of energy does a hospital use? What about the use of water? What about transportation of getting employees and patients to and from? And so he started a whole organization that's called Healthcare Without Harm. Isn't that a great title? Healthcare Without Harm. So the other perspective I would add is this is not just a healthcare book. This is a book that could apply to anything that you're interested in. If you particularly use the examples that we cite in chapter 10 and saying, I've always wanted to get involved, but as we talk about with the Earl Warren story, sometimes I like to talk about having two frogs, one on each shoulder, and the frog on your left shoulder saying, oh, I don't know anything about that. How could I get involved? How could I ask somebody a question? How could I say hello to the Chief Justice of the Supreme Court? And the other frog is saying, why not? Go try it, right? And we all know those things where, because out of anxiety or fear or reluctance, we just let something go by. So our real goal is to inspire and motivate people to action and say, that's an itch that I always wanted to scratch. It's never too late to do something about it. So, Linda, I wanted to bring that perspective into the room very directly, because I think, as one of the reviewers said, I love this book and it should be required reading for all, including students. And, we're all students, whether we're 80 or 20. And that's an invitation for all of you who are here today.
Oh, wonderful. Thank you. Thank you, Blair, for that perspective. And also, I might add in just a couple of minutes, that was a perfect setup when you're talking about climate change and carbon footprint. You're going to begin to hear more from the creation team about this. There are some initiatives that have been started at the national level in the ELCA about churches examining their carbon footprint. So that's in the works. And you will hear more about that as we, particularly timely, I think, at this point, because not only are we changing things here, and we obviously the new chiller is an example of the maintenance that needs to be accomplished, and we have a new campus who has issues. So bringing that carbon footprint to the forefront as we proceed. So thank you, Blair. You set that up very nicely for me. Are there any questions from the Zoom room? We'll start with that group.
Questions at home, or comments?
Well, I'd like to say that these fellows did all this wonderful work while they were real young. They did this in their 20s and 30s. That's so impressive to me. They had the courage to step out and do some really big things, which is interesting too. You can be any age, but these two guys did a lot of stuff, a lot of things, big things, just in their late 20s, early 30s.
We were lucky to have Peggy as a cousin, because, it's always like, well, what should we do now? Well, 1-800-PEGGY. We'll call Peggy and ask her what to do. That's not true, but that's okay.
We use that too, just so you know. I think you've got something.
I just wanted to say how much I enjoyed reading the book. At looking back over my 60-year career in nursing, I could relate to so much of what we were talking about. When I was a student, there were no ICUs. There were, no good treatment for heart disease, kidney disease, all sort of things. And we were just kind of finishing up with the polio. I remember the iron lungs and all of that. And then I particularly like the last section, of course, when you were talking about the healthcare professionals. And I was in the first class of nurse practitioners in Minnesota in 1972. And, again, it was just sort of luck. I heard that nurses were learning assessment skills. And so I went over to the University of Minnesota. And the next thing I knew, I was enrolled in the nurse practitioner program. But it was kind of like reading my history, reading your book, and again, realizing how far we had come when I think back to the days of, no ICUs, no ambulances, no really good emergency rooms. So anyway, I wanted to thank you for taking me down that journey.
Thank you. It's really hard to believe that in America in 1970, there was no single number to call, or 911, that ambulances were station wagons, as Linda said, that there were no EMTs, there were no paramedics, really? There was no trauma system. So you literally went to the nearest hospital and hoped they knew what to do. And there was no real specialty of emergency medicine, as Linda said. The first emergency medicine residency didn't start until later in the 70s in Cincinnati. And of course, now they're everywhere. And the ability to communicate from the field, from the accident scene to the hospital was, maybe a walkie-talkie. And as you know, from your nursing background, there was no ability and authority for EMTs and paramedics to do these life-saving things on the ground because it was viewed as not something you could teach someone other than a doctor to do, right? In trauma, we talk about the golden hour. And the studies then showed if you can get a person who's severely injured on the battlefield in Vietnam or in Houston, Texas, to a trauma center and have a pre-hospital care within 1 hour, the chances are you have at least a fighting chance to save that person. But when you had no system, it was total chaos. There was no training. You couldn't even get access into the system until you got to a hospital and sort of by roulette, get to the right hospital. You're way past the hour. You've already lost. And so it's nice to kind of reflect that was then, but now. But, you go back to transplantation, 40,000 transplants a year successfully. That's good news. The bad news is we have 8,000 people die a day waiting for a transplant. That's 22 people a day. And there's great unevenness in performance throughout the country between how effective organ procurement organizations are in talking to organ donors, talking to families, working with the transplant centers. So we try to bring things up to date in another part of the book and say that was the challenge then. What are the challenges now? Nurse practitioners are phenomenal, and PAs and what those two professions are doing every day in America. We saw it during COVID, but it's even in normal times, it makes a huge difference.
Yes, thank you very much. Any questions from the group here in the room? We got a few minutes. Yes.
I'm wondering if in the book, do they address the role of faith and chaplaincy and stuff and overall in the medical functioning of hospitals and whatnot? And is there a future in that still?
Did you get a
Well, we get into the whole field of medical ethics more broadly, which I think is related to your question, but don't specifically get into the point you made. The Hastings Center on Medical Ethics was started in 1969, and we were fortunate enough to meet the two physicians, a physician and one ethicist who started that organization, and they've been looking at medical ethical issues of all kinds since then. And now they're departments of bioethics, which include religion, typically in virtually every medical school and nursing school around the country. So it's a field that's just burgeoned, and it's a field that I think you're alluding to not only is in the hospital, but something we have to face in the community, whether we should vaccinate or not, whether we should isolate people or not, whether we should require masks or not. We just went through this with our biggest pandemic in 100 years. So medical ethics has now become something that is on the front page of every newspaper.
Yeah, Lucky?
What do you guys see as like the next pressing challenges, the next few maybe pressing challenges in the healthcare world that require some addressing either through creative staffing, like with PAs and nurse practitioners, through changes in how laws work or areas of law that haven't been developed yet that need to be developed to help us kind of move forward and increase and improve the quality of healthcare?
My response to that is, of which there are many, but I think the main one that separates us from other developed countries is we don't have a universal care system, and we clearly need that. So we don't have this patchwork quilt of Medicaid. Care is great for those of us at 65 and over. And then private insurance, which covers some things and doesn't. And it's just very complicated. The electronic record needs to be simplified. It's very difficult to work with. We need to have more rules on the pharmaceutical companies who get away with charging a lot more than they need to. And we all know about the scandals of taking a generic medicine and then coming up with a new trade name and increasing the price by 20-fold. So, and then I think, frankly, the medicine has become more and more corporatized. It's become more of a business. And I think we need to take it back to its roots of care for our fellow man, and have, obviously the business issues are important, but not have it dominated so much by business. So to the point where a lot of doctors and others in healthcare, nurses and PAs and NPs are just getting burned out because they're forced to see more patients per hour than they can. So those are some of the highlights I would respond to your question.
Yeah, I think getting universal coverage, starting with there, is really important. We just have, and I think getting some more regulation and control over these for-profit hospital chains that come into communities totally driven by profit with no regulation, and buy up hospitals and then close them down if they're not making money. That needs to be addressed. That needs to be addressed. I think the breakthroughs in a lot of other areas, it just is getting the systems to work better. So why does organ transplants donation rates, is it 3 times better in some parts of the country than others? So getting the education, people aware of what is possible. But if we don't have people covered universally, then we're behind the game. So broadening with the Affordable Care Act, I think covered about 20 million Americans who were not covered, but we need to take it to the next level.
Thank you. Okay, we have one more question.
It just seems to me some of these issues have now been split nationally, and we've got more fragmentation in healthcare, particularly, issues such as transgender care, women's reproductive care, requirements for vaccination. It seems like those are becoming more, different by states. Is there any effort to kind of create some general consensus within the states? Are we still working to try and get standard laws throughout the country?
Well,
intense
a comment on that. I just think that we are a much more polarized country than we were when we were doing our work. There were just some very difficult things in the 60s in 68, the assassinations of Robert Kennedy and Martin Luther King, and then there was the Richard Nixon presidency. So there were lots of difficult things, not to mention the Vietnam War. And Daniel Ellsberg just died a few days ago, as you know, and the fact that our government was lying to us back then. But the extent, to answer your question more precisely, of the polarization and the lying by certain leaders has reached an all-time high. So I think this is a national discussion in general. It's very much related to ethics and how we want to treat our fellow man and woman. So I think we all need to be part of that. I don't think that I have any extra wisdom on that than any of you do, but I would say kindness should be our number one goal, kindness to each other and taking care of each other.
Thank you.
Linda,
Oh, one more
In
question.
transplantation, is the age of the donor important?
The age of the donor is important, but there is not much in the way of a cutoff if you die and have made a donation. Some of your organs may not be effective for transplantation, but others can be. It's pretty much age unlimited at this point.
Yeah,
And you
just-
can also make a donation of you can make a donation of your body for medical research, which is a real important contribution at any age.
And to go back to the story of my stepmother, age, I believe, was a factor because she was older at age 77. The gentleman who died was 66. So I think the fact that it was an older liver helped facilitate her getting it. A 20-year-old who was waiting for a liver may or may not want a 60-year-old liver. So I think age comes into play in certain cases.
It depends on.
It depends on all.
And different people's organs are at different health rates, not unrelated to age as well as to age.
Depends on how that gets complicated, but yeah. Well, thank you very much, and a special thank you again to Kathy for hooking me up with this book. I so appreciate it. So try to stay cool and have a wonderful 4th of July.
Water comment. One of the things that was triggered by both what you all said and you said was chapter 10. And what can you do and how can you make a difference? Well, we're there as a congregation, right? We have a new pastor coming, we have a location, you know, how can we all and what do we all and how do we as a congregation? It's very exciting.
Yeah.
An opportunity for us. And maybe those principles, you know, that might be useful for all of us to take note of and to think about.
Absolutely. Well, thank you all again. I really appreciate it.
Thank
Linda,
you.
thank you for the opportunity.
Thank you, Fred and Blair.
Thank you, Maggie.
Love you.
Bye-bye.
Thank you, Peggy.
So good to have them.
Yeah.